Hi, everybody. Welcome. My name is Warshofsky. I'm the system chair for the Heart and Vascular Institute at Nuvance Health. Welcome to our roundtable discussion of valvular heart disease. With us tonight, we've got Dr. Richard Kaplon. Dr. Kaplon is our chief of cardiac surgery at Danbury Hospital.
Hi, Mark.
We have Dr. Arshad Yekta. Dr. Yekta is our director of the cardiac catheterization lab at Norwalk Hospital.
Thank you, Mark.
And we have Dr. Zubair Jafar, who is our director of structural heart disease at Vassar Brothers Hospital in Poughkeepsie.
Good to see you, Mark.
Welcome, everybody. So I just wanted to get started here with the basics. And I'll start with you, Rich. What do we mean by valvular heart disease?
So the heart's a pump, and it's composed of heart muscle. It has blood supply, and then it has valves inside the heart to keep the blood moving in one direction. Those valves can develop disease processes, either congenitally at birth or over time deteriorate or as a consequence of disease processes. And so when we talk about valvular heart disease, we're talking about the dysfunction of one or more of those valves inside the heart.
Great. So they become leaky or blocked, depending upon what the disease may be. Is that right?
Exactly.
Got it. Go ahead. You were about to say something.
Or some combination of the two, leaky and or blocked.
Yeah. Okay. And Zubair, what are we doing now with treatment for these different valve diseases? What are the different valves that can become diseased, and how are we approaching them?
So there are 4 valves of the heart, 2 on the right side, 2 on the left side. And those are the tricuspid and pulmonic valves on the right side, the aortic and mitral valves on the left side. And each of those valves can individually get affected, as Rich mentioned. And over the last 8 to 10 years, they've been evolving therapies and how to treat those valves. So it's probably easier to discuss each of the valves separately, but certainly every one of those valves can be treated through many different ways. And so we have different technologies available, and certainly myself and Rich would work together to try to figure out what the best treatment would be for that patient for that specific valve. Got it.
So Arshad, if you talk about kind of your most common valves that get treated by us as cardiologists or surgeons, we're talking mostly, let's say, about the mitral valve and the aortic valve. Would that be correct?
Yeah, that is correct. Yeah, the aortic valve and the mitral valve are both left-sided valves, and the left side of the heart is the structure that pumps blood to the majority of your organs: your brain, your kidneys, your coronary arteries, your lower extremities, and your stomach. And usually these are the valves, when they have dysfunction in them, become more symptomatic. So people really notice that they may develop symptoms like shortness of breath, or other symptoms like lightheadedness, dizziness, or even discomfort in your chest. So in general, symptoms become more readily apparent in those valves than the right-sided heart valves do.
And so when we talk about treatment for valve disease, what exactly are we talking about? Can you treat these issues with medications, or do you have to do other things to address them?
Yeah, that's a really good question. And, there are many things that can be done. And it stretches the gamut. Obviously, all of us, have valves, and there could be some tiny amount of leakage in some of these valves, or even some thickening of these heart valves. Not all of them need to be treated. So some of them can just be watchfully monitored, and we can use careful physical examinations, auscultation with our stethoscopes, and also echocardiography, which is ultrasound of the heart, including the pump and the valves, to assess the degree of dysfunction in those valves. Once you determine that the valve has issues, then you can decide what kind of treatment. And the treatment, as you mentioned, do include both medical treatment and also more mechanical issues. So medical treatment could be related to medications for blood pressure, for example, for mitral valve disease or aortic valve disease, in particular leaky valves and things like that, or if you have a thickened or what we call stenotic, which is basically the valve doesn't open up too well in the mitral valve, you can also use medications like beta blockers to slow the heart rate down. So now, once you've exhausted medical options for these patients and they start developing symptoms such as shortness of breath or even more serious issues like congestive heart failure, then we really start thinking about more advanced maneuvers like valve corrective procedures. And that would include both percutaneous approaches and open heart surgery or surgical valve approaches that Dr. Kaplon or Rich may perform. And there are many different types of valve procedures that we perform, but from a percutaneous perspective, they include valve replacement and also valve clips. And I'm sure Rich can talk to you a little bit more about the surgical aspects of corrective valve techniques.
Great, thank you. We're going to talk a lot about the treatment, but Zubair, how does a patient know that they might have valve disease? What would they be feeling? What would they experience?
So typically the most common thing is shortness of breath. So the typical complaint is someone used to be able to do certain things and now they notice they go up a flight or 2 flights of stairs and they're short of breath, they're winded, they have to stop. Sometimes they'll complain of dizziness, lightheadedness. And then as that progresses, they may also complain of swelling in the feet. So those are the typical symptoms. Sometimes people will start to complain of fatigue as well because they're not getting enough blood flow. So those are sort of the classic symptoms that we see. When it progresses, certainly we can have congestive heart failure where basically fluid backs up into the lungs. They could have syncope or passing out because the valve itself is so tight that then it's unable to provide enough blood supply when the demand goes up. So those are more advanced symptoms.
And Rich, when we talk about the surgical approach to treating heart valve disease, I know that's changed in recent years, certainly a lot of new techniques. But could you give us a sense of kind of where it started and where it's going now?
Sure. So historically, operative valve surgery required dividing the breastbone, opening the chest, connecting the patient to the heart-lung machine, stopping the heart, and then replacing the valve. The next iteration or evolution in that process was we learned to repair some of the valves, specifically the mitral valve. And then sort of during the 1990s, we started looking at alternative incisions, less invasive approaches, not dividing the whole breastbone, just cutting a window in the breastbone, or maybe coming in through the side and just working between the ribs. What's been really nice over the past 10, 15 years is our technology is tremendously advanced. And I think there's been two major advances in the care of valvular heart patients. One is that we've developed a very cohesive team approach involving cardiology and cardiac surgery. So you have a lot of brains at the table when you're thinking about one patient. And that's been a real advance in terms of how we care for our patients. And then secondly is we've developed techniques for some types of valve problems where we can actually correct these either with small incisions in the chest or just with needles in the groin. And so we have an entire spectrum of options depending upon what a specific patient's issues are.
Great, thank you. And you mentioned this heart team approach. Zubair, I wonder if you could talk about that a little bit more and how kind of decisions get made within that heart team.
That's a great question. So as Rich talked about, close to 10 years ago when multiple approaches were coming into play and patients had multiple options, I think the societies of cardiology and cardiothoracic surgery got together and decided the best way would be a multidisciplinary comprehensive approach. So if a patient is referred for valvular heart disease, they usually go to what's called a valve clinic. So it's a place where the entire structural heart team gets to meet the patient. So the surgeon, the interventional cardiologist, and the entire structural team will meet with the patient. And after discussing with them all the options we provided the patient. So allows the patient to come one time and meet the entire team, and decisions are made in conjunction with the cardiothoracic surgery and cardiology, as well as the patient's primary physician and primary cardiologist.
Great. So let's say we decide a patient is a candidate for a TAVR. I know much of our audience has heard about TAVRs. They may not know exactly what it is. Arshad, can you clue our audience in about what a TAVR is and what the patient would experience if they get referred for one?
Sure. So TAVR stands for transcatheter aortic valve replacement. So as Rich mentioned, it is an approach by which we use catheter-based procedure, so really minimal incisions and needles and catheters to replace the heart valve. So, you know, the way that it's actually performed is there's multiple ways. These days, the most common way of replacing the heart valve is through what we call transfemoral technique, where we put a catheter, which is about 5 millimeters in diameter, or 5.5 millimeters in diameter, into one of the arteries of the leg. And then we're able to use wires and a balloon to pass over a stenotic aortic valve. So we put a wire through this valve that's not opening too well, and then we use this catheter to insert this artificial valve in. Then we use balloons to inflate the valve, and actually we don't take out the old valve at all. What we do is we actually cover the old valve and actually kind of move it away from the, eliminate it from its function. So the new valve replaces its function entirely. And the other valve gets pushed away and is not really functional anymore, but it's really not doing any harm, even though it's still there. I know with the aortic valve surgery, the valve is cut out, but with these new techniques, we're able to move the valve out of position. So in general, that's the procedure itself for a TAVR. And in general, the way, as Zubair mentioned, if these patients are referred for TAVR, we start off with the multidisciplinary approach, but the most important thing is just understanding that these are procedures that are thought about quite deeply by multiple individuals and on an ongoing manner. So you meet our valve team, but then through every step of the procedure, there's always somebody there kind of guiding our patients. I think that's the most important thing. Is it's not as if, okay, I make a decision, I'm going to get a TAVR and I'm going to come in on Wednesday and get my TAVR done. It's understanding what the process is, understanding that what the steps are. For example, do you need a CAT scan before? Do you need a cardiac catheterization? And we have our mid-level nurse providers that really guide our patients through this process. I think that's the most important thing, is that you're never alone as a patient. You're kind of on this journey with us together, and we're all constantly thinking about you. We meet with our valve team every week just to making sure that all our I's are crossed, all our T's are crossed, all our I's are dotted to make sure you get the most effective care.
Great. And Zubair, can you talk a little bit about the MitraClip, addressing the mitral valve specifically, and how that is as an option and what patients may experience with that?
Great. Just to continue what Arshad was saying, the TAVR has been the predominant approach in the aortic position and has done very well. And many of our patients do get a TAVR for the aortic valve. The mitral is still a different story. We haven't quite solved that issue from a catheter approach. So predominantly, anybody who has mitral valve disease should undergo a surgical option, and that would predominantly be most of the patients would have a surgical option. For those patients who cannot undergo surgery, so Rich would see the patient and say, hey, this is a high risk patient, whether due to comorbidities such as kidney failure or bad lungs or their age, and then they would not be a candidate for surgery or very high risk for surgical approach. Those patients would be qualified for a MitraClip procedure, and that is a transcatheter procedure, so it's minimally invasive. Again, as Arshad mentioned, we would put a 5 or 6 millimeter catheter through the vein in the leg, not the artery, and be able to then cross over the heart using a small needle into the left side of the heart. That allows us access to the mitral valve. And when the mitral valve frequently, in this particular case, is not functioning properly, that it's leaking too much. And so so to speak, the doors of the valves are not opposing each other, and the blood is leaking back into the lungs. So we're able to put a clip on those leaflets, so it prevents that valve from moving so much and can reduce the amount of leakage that occurs from the mitral valve and prevent heart failure.
Great, thank you. So Rich, I know there's been a lot of buzz about all these catheter-based techniques, and like you guys mentioned, we kind of, with the patient and the patient's physician, decide what the best option is for each individual patient. But you know, for the patients that aren't a candidate for the catheter-based techniques and are candidates for surgical approaches, but they say, you know what, doc, I want to have the smallest incision possible or the least invasive surgical procedure possible. Can you talk a little bit more about what options there might be for those patients?
Sure. So number of options surgically for the mitral valve. And just to digress, if I may, one of the things that we've talked about, particularly for the aortic valve, is that symptomatology is a key factor. Interestingly, for the mitral valve, we have very good data that shows that when one has a severely leaking mitral valve, even if that patient does not demonstrate any symptoms, they feel fine, that correcting that leak actually returns that patient to a normal survival curve. So I do think it's important that symptoms are not the only thing we look at. We need to look at these valves and how well they're working. But to answer your question, so the classic approach for a mitral valve repair or replacement would be to divide the breastbone. There are multiple iterations as to how to approach that valve in a less invasive manner. There are two most common approaches these days. One is what I will call a minimally invasive approach, which is a 2 to 3 centimeter incision underneath the right breast and a couple of needle holes in the groin to access the femoral artery and vein. The other is a robotic approach. And really this comes down to surgeon's preference, what one is comfortable with. There are centers that do an excellent job with robotic surgery. The issue with the robot is that it creates more holes in the chest wall, and it is a little bit more expensive. I'm not sure it conveys any clinical benefit, but for patients who like having robotic surgery, it's an option. Our approach at Danbury is a minimally invasive approach. So a 2 to 3 inch incision under the right breast. We don't spread the ribs, we work through that space. And through that, we're able to repair or replace the mitral valve as needed.
Great. And there are some minimally invasive options for aortic valve surgery as well, right?
So similarly for the aortic valve, if one has isolated aortic valve disease, the coronaries are clean, there's no other valvular heart disease, there are two approaches that we typically use for that. And that is either to cut a small window in the upper half of the breastbone or to work through the chest wall on the right side. My experience, I prefer the window through the breastbone. I find going into that space between the ribs on the right side for the aortic valve is a little less comfortable for patients. Patients tend to heal more quickly when you cut about a 3.5 inch just window through the breastbone.
Great. Well, I want to thank everybody for joining me tonight and hopefully really getting the word out about all the options that are available for patients with valvular heart disease here at Nuvance Health, at Danbury Hospital, at Vassar Brothers Hospital, and at Norwalk Hospital. And really, I thank you all for your time and for your expertise.